My name is Gloria Karekezi, and the title of my thesis is Decoloniality and Re-existence, addressing disparities in Black birthing and decentering Western authoritative knowledge in public health. My thesis begins with an introduction explaining the disparities between birthing outcomes for Black birth givers and their counterparts of other races in the United States, ultimately centering around the fact that Black women are 3 to 4 times more likely to be affected by maternal mortality than their white counterparts. This inequality and these inequities are generally portrayed as central issues to birthing equity, yet research and scholars often overlook the white supremacist historical context that has long contributed to unequal birthing outcomes for Black birth givers. In a country built on the abuse, exploitation, and dehumanization of the Black body through the slave trade, chattel slavery, and long continued traditions, racism and anti-Blackness are inherent to the long-standing institutions in the US. This inequity has been achieved historically through the disempowerment of Black birth givers' collectivism, agency, and bodily autonomy through the dismantling of Black knowledge systems and the institutional control of birthing, parenting, and reproductive health. Decoloniality, which I explore in this paper, coined by scholars Anibal, Quijano, and Walter Mignolo, um, refers to the acknowledgement of the sources and geopolitical locations of knowledge and the affirmation of indigenous modes and practices of knowledge that have been denied by the dominance of white supremacy through epistemic reconstitution. An epistemic reconstitution, which is a term coined by Quijano, refers to the detaching from the ways of existing, thinking, and being that are grounded in the logic of coloniality and the rhetoric behind modernity. And this means questioning and changing how, why, and what we think. The operationalization of decoloniality theory is central to understanding the relationship between colonialism, coloniality, modernity, medicalization, and dehumanization in the context of Black birth givers in the United States. I began this paper by using social theory to frame how race is inherently relational, and it's understood as the result of social relationalities established over time, rather than something determined by biology and body or the inherent characteristics in the people racialized. In Western Euro-American society, white supremacy continues to reside at the core foundation of socioeconomic organization. And regardless of the modern diversity of nations, such as the United States, the United Kingdom, or Canada, the structure of society itself is white and upholds white supremacy. In the United States, this holds particularly true and deeply intersects with slavery, systemic oppression, and myth maintenance. My paper then goes into the public health etiologies surrounding the disparities in birthing. This includes increased cardiovascular morbidity for Black birthers, racial bias, site of care, access to care, structural violence, and the role of differential treatment. I explore the role of structural violence through the strong Black woman or superwoman role to highlight the popularized perceptions of Black women and femmes both within and outside the medical field. I also briefly discussed the increase in cesarean sections and the disproportionately higher rate that Black women receive them at, ultimately revealing how institutionalized medical practices, such as prescription medicines, surgical transformations, and the use of medical technologies fortify existing institutional racism. I next historicized the Black birth givers narrative, showing how legacies of slavery, racism, modern obstetrics, and gynecology have largely influenced contemporary challenges faced by Black birth givers and their poor maternal health outcomes. In order to understand Western medicine's proximity to white supremacy and anti-Blackness, we first understand how Anglo-American knowledge production was shaped at the expense of Black lives. This is imperative for more efficient examination of the context of white supremacy and how it gives life to the public health field, research, and intervention today. I explore the erasure of social childbirth, increased surveillance of Black women and Black bodies, the disenfranchisement of midwives and alienation of midwives, and the experimentation on Black bodies and racialized science techniques. I also highlight how many obstetrical beliefs and practices today have been influenced by the shifting of authoritative knowledge in pregnancy and parturition from women and informal birth workers to physicians and scientists, and how, in excluding culturally competent knowledge from the formation of obstetrics and gynecology, white men effectively centered their ways of knowing as truth in respect to birthing. In a white supremacist country, this works to the disadvantage of Black women and Black birth givers, as white narratives perpetuate false ideas, such as that Black people do not feel pain as other races do. This is explored further in the paper through direct evidence. The failure to acknowledge and address racialized conceptions of health has created a barrier to providing adequate and culturally competent care for Black birth givers and patients as a whole. I next explore the control of the Black body in American systems and culture, manifested through other forms in addition to slavery and the history of gynecology and obstetrics. One form is systemic regulation of Black birthers through the fronts of popularized eugenicist beliefs and forceful sterilization, which were particularly common only a few decades ago. I also explore how social programs preyed on Black women and those of other marginalized identities, such as immigrants, low income, and disabled women, by offering social services in exchange for consent to sterilization. And these services included daycare, SNAP, Medicaid, and housing assistance. This brings light to how the abuse of Black bodies not only became normalized, but was integrated into the epistemological practices of medical institutions. An institution which sees Black bodies as means of practice inherently communicates to its audience that Black people merit dehumanization, control, and lesser autonomy. In pregnancy, Black bodies suffer at the perils of both racialization and medicalization as they are inserted into a racialized medical system. Black birth givers are subjected to biases and assumptions in regards to their bodies, self-awareness, and personal practices, all which have been shaped by an inherently and historically white supremacist society. I then go into framing and applying decoloniality theory and explain how the decoloniality of birthing requires that we question the empirical science and Western knowledge production that shape recognized practices in the medical field. In Quijano's model, global Eurocentric hegemony is articulated around the axes of coloniality and modernity. The process of modernity ideologically constructs the world in a way which rationalizes and upholds coloniality while introducing institutions that inherently naturalize colonized and colonialized peoples as inferior. In the United States, the medical institution, along with the medical agents, actively uphold this coloniality and modernity through institutional, structural, and interpersonal and internalized forms of racism. I also explore and present how a central component of the decolonial ethic is moving away from hierarchizing different forms of understanding and rather focusing on uplifting and fostering discourse between these diverse traditions to improve our understanding of the world. This is necessary to understanding the importance of decoloniality in birthing and birth practices. Through a decolonial lens, approaches to birthing and healthcare, such as those integrated in complementary health models, can become more comprehensible and accessible. However, equitable distribution and access to knowledge is most possible once Western epistemological traditions built on abuse, dehumanization, and destruction of Black bodies are no longer presented and validated by the global community as truth. In the last section, I look towards re-existence through I address how Black birth givers and allies around the United States are increasing understanding of Black maternal mortality while also creating spaces for decolonizing birthing through patient-centered practices. These examples of re-existence are brought forward through uplifting models which engage with traditional, indigenous, Black, and non-biomedical forms of health and care. Reproductive justice is a critical movement that's used in this section. I explore the Roots of Labor Birth Collective, which is a community-based approach in Oakland, and it addresses public health concerns such as poor birth outcomes, declines in mental health, and recidivism, while simultaneously rejecting the colonial matrix of power that Quijano refers to. I also explore the Black Woman Birthing Justice, grassroots organization based out of Oakland that is committed to transforming the birthing experiences for Black birthers through empowerment. I further unpack how, through educating a wide range of audiences, from college students to policymakers, healthcare and birth professionals, and everyday community members on birth justice and reproductive justice, they challenge hegemonic Anglo-American authoritative knowledge and bring into light traditions, practices, and ways of thinking that have been oppressed. Thank you for listening.